All right, so we're going to get started. So we're going to talk about waveform capnography, looking at the numbers and looking at the waveforms, and really getting down to the importance of why we do this. And I'm just going to ask you guys this question here is, when do you not use it on a patient? And I'm hoping that will change your mentality by the end of this program on how many times we should be actually using this versus not, and all the different types of patients that we come in contact with. I know there's a cost for these, but to me, cost does not override patient care. And there's a lot of things we can do to kind of see how things are going, where things are progressing, just looking at the waveform and the numbers. So the difference between oxygenation and ventilation. So what are your thoughts as a group? What do you think the difference is between oxygenation and ventilation? So we look at oxygenation, which is the ability of having or the red blood cells to pick up oxygen and move them to the tissues of the body, right? So we take that breath in. We're going to go over cellular metabolism here in a second. So we take that breath in, oxygen comes in. As we exhale, carbon dioxide comes back out, right? That's the basics of this. Oxygen in, travels round and round, off gassing, carbon dioxide. We're going to go, like I said, the next slide, we'll go a little more in detail with that. Ventilation is the exchange of air between the lungs and the environment, including inhalation and exhalation. So oxygen comes in, we take that ventilation, so the air comes in, inhalation, it attaches, moves through the body, comes back off gases with carbon dioxide, and that's our inhalation and our exhalation. Right, so let's go into cellular metabolism a little bit. This will try to start making a little bit more sense. So oxygen first must be picked up by the red blood cells and then dumped off at the tissue level, right? That's our capillary bed at the tissues. So if you follow the heart here, right, as we're exhaling, bring that back a little bit. As the body is moving blood back towards the heart through the superior and inferior vena cava, it is deoxygenated blood as it comes back around. It enters the right atrium, which is deoxygenated, right, through the tricuspid valve, deoxygenated right through the right ventricle, through the pulmonic valve, through the pulmonary artery, deoxygenated here. In the lungs, that is where it is dropped off. That's the carbon dioxide, that waste product is being dropped off. As it's being dropped off and exhalation happens, CO2 is then expelled. As a breath comes back in, now we're entering that pulmonary vein. Okay, and this is at the capillary level. Let me rephrase that, at the alveolar level. As that's happening, oxygen is then attaching to the red blood cells, the hemoglobin. Sorry about that. To the hemoglobin, and then is being transported through the pulmonary vein into the left atrium, passing through the mitral valve, right, into the left ventricle. For the left ventricle, it is going through the, oh, it keeps changing on me. It is going through the aortic valve into the ascending aorta, into the aortic arch, and then back down through the descending aorta. And that's where it's going to expel off into the body. So as it's going down the descending aorta, up top, by the way, on the aortic arch, you have your subclavian arteries and your carotid arteries up here. It drops back down a little bit lower. You're going to have your renal arteries going to your kidneys. And then as it goes down even farther down the aorta, you're going to have your femoral arteries that branch off to the right and left leg, right? By going through, it goes to the arteries, to the arterioles to the capillary bed, where oxygen is then exchanged to the tissues, and then comes back around again through the venules to the veins, back to the vena cavas, back to the heart again. So that's kind of how the blood circulates through. That's important for oxygenation, for that cellular metabolism. We have to be able to monitor both, right? And there's two things that we can do to monitor these patients. One is pulse oximetry, And two is capnography. And more importantly, not just the number, but the waveform, right? We're looking at both number and waveform together. And that's where the cellular metabolism is now measured, as we can see here. Pulse oximetry measures the oxygenation and can be improved or be provided in a waveform, as you can see with the blue circle. What you're seeing here is what they call a pleth. So pleth is the ups and downs of that waveform. If you have a waveform that kind of looks like this, like that, that is not decent pleth. Therefore, you're not getting an accurate measurement, right? So if you have a Zoll X series monitor, I can't speak much for the LifePaks, but the Zoll X series monitors, all right? If you have one of those, scroll down to the SpO2 in the corner. You'll see the yellow box like this. You'll see SpO2 and it gives you that reading. And highlight that and click on that. And in there, you'll have something called sensitivity. And you can change your sensitivity level from normal to maximum, and that'll give it more infrared reading. Therefore, if you have a patient with cold hands, things like that, you might actually get a more accurate reading with that if you change the sensitivity levels. Right? Most of the X series monitors have that. But that's going to be our waveform looking for the SpO2. The other waveform we're looking for is capnography. And this measures the ventilation and also can provide a graphical waveform for interpretation. So we look at our pulse ox here, check that one off. That is oxygenation, and capnography is ventilation perfusion. So is our body actually perfusing and ventilating appropriately to provide good oxygenation? Are we off-gassing appropriately? And there's things that we're going to come into later on in the presentation that will talk about what can cause changes in that waveform and how can we fix that at the EMT, advanced EMT, and paramedic level, and the things that we can utilize. And as always, I speak to the national standard. So you should know your state protocols, what you can and can't do, but I'm going to cover the national standard, what can be administered for this. All right, so we're going to look at that waveform. We're going to go more in depth on the waveform here and how this inhalation, exhalation phase actually works. And I do have the chat box open if anybody wants to ask a question through the chat box as well. I can try to answer those as we move forward. So oxygenation is measured with pulse oximetry, or the SpO2. Keep in mind that these are all tools, but does not take away what you can actually physically see going on with your patient. Okay, these are all tools of the trade that helps us with differential diagnosis for treatment. So oxygenation is measured with pulse oximetry, or SpO2. It's a non-invasive measurement, so it does not hurt the patient. Expresses the percentage of oxygen in red blood cells. Okay, this also changes in oxygenation may take minutes to be detected, like up to 5 minutes at a time before you start seeing these changes. So this is affected by motion, artifact, poor perfusion, nail polish, and some dysrhythmias of the heart. So we talk about the red blood cells, that hemoglobin, right? All that stuff that's in the blood. If you have a patient that is bleeding out, internal bleeding, external bleeding, right? Are you going to get accurate pulse oximetry readings, for one? Can you? And two, are we going to have good perfusion, right? So when you got a patient who is actively bleeding, or say hypovolemia, based on blood loss, if we're treating it with just fluid replenishment, lactated ringers, saline, whatever your drug of choice is going to be, these patients are not going to get oxygen. What they need is whole blood. They need that hemoglobin. They need those red blood cells to be able to actually have oxygen attached to it. If we don't, then we're just turning that blood into Kool-Aid, and that Kool-Aid is not going to help perfuse the body and oxygenate the tissues, therefore going into shock. Shock leads into seizure, coma, death. Patients die, right? So we got to catch that early stuff that's going on. So one of the body's mechanisms for that oxygenation, if we have the ability or the lack of red blood cells, is that patient is now going to have tachypnea. Why? Because now they're trying to bring oxygen back in faster. They're going to be tachycardic because now they're trying to pump the heart faster and move that blood around to help that inadequate state of tissue perfusion, that shock state, and now we're in compensated shock. Why am I bringing up trauma to this initially? Because we need to make sure that we're oxygenating these patients. Even though their SpO2 may be higher, if they're losing blood, we need to give them more oxygen, right, to help perfuse the tissue. So that's why I kind of brought that into it. We look at our different waveforms as well, looking at oxygenation, is our pulse oximetry waveform. So as you can see on the top one, that's what we call normal pleth, which is a normal heart function. If the heart is skipping beats or that irregular heartbeat, we're going to see what they call the flat line here, because there is nothing perfusing at that point in time. So when we're looking at our infrared, it's actually measuring the pulse. It's measuring our heart rate and looking at what kind of what is attached to that hemoglobin. Right? Irregular heartbeats, as you can see here, they can be up top high, they can be down low, or if there's a weak signal, you have that very low pleth that's there. If you start seeing the really squiggly lines like this, right, you're not getting an accurate reading. The hands may be too cold. The infrared may not be working very well. There could be nail polish that's on there. A lot of things could be changing what you're actually seeing for reading. So look at your patient, right? If they're hypoxic, they're going to be potentially cyanotic, fingertips around the lips, around the nose. If you're starting to see that kind of stuff there, they're pending failure at that point, right? They're past that respiratory distress. They're getting into that failure category, and you start seeing that central cyanosis, right? So we got to make sure we're catching this stuff early. And we're going to go over a little thing together here in a project. And I don't know if you guys have your cardiac monitor out and things like that. Do it afterwards as a group and just kind of try this out. Or maybe on a break, you could take out your cardiac monitor and try it out. We're going to go over that little little task here in a little bit. So we're looking at our different waveforms on our monitor, looking at our normal, whether it's irregular, things like that. Okay, now let's go into ventilation. So ventilation is measured by end tidal CO2. And the reason why it says end tidal, we'll kind of cover that here in a little bit and where that end tidal reading comes from. But it's a partial pressure or volume of carbon dioxide in the airway at the end of exhalation. It's a breath-to-breath measurement that provides information within seconds and not affected by motion, artifact, or perfusion, or dysrhythmias. We're still going to get a reading. Whether it's a good reading or a bad reading, if they're acidotic or alkalotic, does not matter. We're going to get a reading. It's going to give us something, and it's going to be accurate. Now, we mentioned before in the previous slide, I'm going to go back here. Look at this number here. Let's circle that for you. 5 minutes can go by without your SpO2 changing. So if you had an SpO2 percentage of 99, that could last about 5 minutes. 4 minutes, 3 minutes, with no oxygenation. I'm talking about a patient that went into respiratory arrest. And if you're not paying attention to them, you're not going to see that change. If you look at our ventilation and measured by end tidal CO2 monitoring here, within seconds, you're going to see a change because the breathing is going to stop. And you're not going to be able to get those readings anymore, and apneic alarms will go off, right? So now you're going to see a true reading at the time things are changing. All right, we'll get more into, like I said, more into the end tidal readings here shortly. That's why it's important to measure our ventilation, because if we're not ventilating appropriately, we're not oxygenating appropriately, they kind of go hand in hand, right? So if we have a patient who is bronchoconstricted, and we have mucus build up inside the lungs, moving into the bronchioles and things like that, we have that bronchial inflammation. We're not going to be able to off-gas appropriately and or maybe even oxygenate appropriately, like our COPD exacerbation patients or asthmatic patients, things like that. Even our anaphylaxis patients, we have to do different treatments to help oxygenate the system. So we're going to talk about those different obstructive and distributive types of shocks that we might come into with this. So these are capnography capnography waveforms. As you're seeing on this first one here, this is a normal waveform, right? We're going to go over our different numbers here in a little bit, but this is our normal waveform. We have our inhalation here, then we start our phases, exhalation, plateaus off, and then inhalation back down again, and then comes across, right? What we're measuring on the end tidal is the very end here, where that cross is. That is going to be our end tidal reading that kind of goes across back here, and it kind of gives us our number. Our magic numbers for end tidal readings, right, is 30. Let me write these out right here. 35 to 45 is going to be our normal range for end tidal. Right? Our normal pulse oximetry reading should be 94, 99%. We don't want 100. Right? That's going to be our normal readings here. What we're really focused on, though, is this. If we can't perfuse appropriately, then we're not going to be able to fix this. Okay, so we got to make sure we're perfusing appropriately. B and C, right, could be inaccurate readings, or the patient is no longer breathing, now they're apneic. Right, so let's kind of go into the difference. Now, we talked about this stuff here already between oxygenation and ventilation. Let's put those two together so we can actually see what's really going on. Right, so oxygenation and ventilation. Oxygenation is oxygen for the metabolism, right? It provides SpO2, which is measured percentage based on oxygen in the red blood cells, and reflects change in oxygenation within 5 minutes. Underline that again. Then we have our ventilation, which is carbon dioxide from metabolism, not for, but from. End tidal CO2 measures exhaled carbon dioxide at the point of exit. This reflects change in ventilation within 10 seconds. 10 seconds. So those are huge numbers, right? If we can't ventilate, we can't oxygenate. That's just the way it works. We got to make sure that we're actually providing good ventilation. And we can look at that based upon our waveform readings. Again, we'll get into this up here shortly. And if you guys don't believe me, try it out. Find someone that's in your class, in your station that can hold their breath for a long time. Put them on a pulse oximeter and waveform capnography, and have them hold their breath and see how long they go. Watch what happens to the SpO2 and how it doesn't change over the course of 2 minutes. But watch what happens within 30 seconds when you start getting apneic alarms, your patient's no longer breathing. Right? So turn it on, hold your breath, and then you can actually see immediately the capnography show apnea. The SpO2 will still show a high saturation because it does not register for several minutes that's there. All right, let's move forward. So we talked a little bit about what it does, how blood circulates through the body, how we can oxygenate. Now let's bring in the pre-hospital use and why we're doing it. So utilizing capnography, so immediate information via breath-to-breath monitoring. I want to know exactly what's going on pre and post treatment. So if I have a patient who is showing bronchoconstrictive waveform and I start giving bronchodilators like albuterol or duonebs, things like that, I hope to see that I'm going to start seeing the bronchoconstriction go away. We have bronchodilation, and I started seeing more of a normal waveform. So I can actually trend my treatments and kind of see what's going on with these patients as I'm making them hopefully better. Or is it getting worse, and do I need to go down a different path? Right? So information on ABCs, airway, breathing, circulation, and also helps with documentation purposes. Right? So here we are at the EMT level, the paramedic level, we're using advanced airways now, right? We're using SGAs and things like that. So supraglottic airways like Kings, iGels, LMAs, all these different supraglottic airways. And then when for the paramedic level, we're using endotracheal, so the paraglottic endotracheal intubation, right? This helps as a documentation purpose to show that our tube or our airway is in place. If we're seeing numbers, we're seeing readings. That helps us out tremendously, right? It helps confirm we have a good patent airway. We have good breathing. We're circulating blood appropriately, hopefully. We're getting good perfusion, good ventilation. Right. So with airway, it has verification of ET2 placement. It also verifies supraglottic airways and continuous monitoring of ET2 position. So if somebody intubates a patient and the tube becomes dislodged, we're probably going to see a reading like this here. We have go up, we have our reading, come back down again. Same thing, and it starts going down and down like this, right? So did the tube get dislodged around this point here, rephrase that, this point here, and we lost that intubation, right? So we start seeing that we don't see any more movement. That could be the fact that ET tube was just now displaced. We can use it for breathing things as well, like for example, hyper and hypoventilation. We're going to see the differences in height, duration, and rate between hyper and hypoventilation. We're going to look at our asthmatics and our COPDers, looking at our bronchoconstrictive waveforms. So let's get into that. And this stuff here, these two right here, right, are going to be very important when we start talking about closed head injuries later on in the presentation. And for circulation, it checks the effectiveness of compressions during cardiac arrest. It's also the first indicator of ROSC. This is an important one here. And then it monitors low perfusion states. So what we're looking for in the first indicator of ROSC is you're going to see a spike in end tidal, usually around like 60, 50 or 60, and you'll have that spike before you even get a pulse back. Okay, so if you start seeing that spike and that change, start expecting ROSC by the time you guys stop your CPR and you start getting into your pulse checks and everything else, you're going to probably have a pulse at that point in time, right? Some of the things we're looking for with this is low perfusion states. We're going to cover that more later on in the presentation. But again, it checks your effectiveness. So, Jackson First Alert, you guys have a Lucas device. That thing provides absolutely phenomenal compressions. It really does. I'm a big fan of the Lucas device. And with that, you're probably going to see higher end tidal readings. So that thing does such a great job with piston compression that it might actually generate a blood pressure. So just keep that kind of stuff in mind. That's why it's so important to have mechanical CPR, because it doesn't stop until your battery dies. Where we as human beings, we get tired, right? But that helps check our effectiveness to make sure we're actually perfusing the body appropriately for getting end tidal readings. Another thing to look for as well for documentation purposes and use of circulation, if you get to a cardiac arrest and the patient is obviously no pulse, not breathing, you start CPR, you put an end tidal chimney on your BVM, or you put in a supraglottic airway, and you have an end tidal reading of 20. You have a very high chance of getting pulses back. Usually less than 10 on initial start. It's very rare you might get a pulse back, and if you do, the lifestyle of living afterwards may not be the greatest. They may stay on a ventilator at that point in time because of the fact they haven't been perfusing very well for a long period. So again, some other indicators. I'm not saying that if you have a reading of 5, you just call it in the field and say we're not going to work this cardiac arrest. It's just other indicators to kind of help state your cases with it. As far as documentation purposes go, as with all documentation, capnography can be utilized as a legal evidence pertaining to the care that the patient received during the call. Your cardiac monitors do not lie. Okay. Now, can they have false reading, erroneous readings? Absolutely. But it tells you what you did and what you did not do. So if you go to a cardiac arrest, you go to any kind of call and you say, I put end tidal on, we can pull the data from that cardiac monitor and say, you know what? You never put it on, never turned it on, never even got connected. Because all that stuff is tracked every single time you turn that cardiac monitor on in detail. In detail, it shows you, especially with the Zols. You can do the same thing with the life packs. So it's documentation purposes. If you're putting it on, utilize it because it can actually save you. It actually shows proof that you've done certain things, or it shows proof of your trending. Whether it be good or bad, if you're showing treatments and your trending is there, it will actually help you tremendously. The following are examples of information that capnography provides. One is a baseline capnography assessment. Where do we currently sit prior to treatment? It gives you a waveform appearance, so it's showing that the patient's actually breathing. It gives you a waveform, whether it's bronchoconstrictive, hypo, or hyperventilatory. That's going to be more part of your assessment, but it shows that there's something going on. And then it changes in the waveform with treatment, that trending that I was talking about. If we're giving bronchodilators, if we're giving magnesium, if we're doing corticosteroids, if we're whatever we may be doing, good CPR, it shows that our trends are there. And then end tidal values, where documentation of the actual numbers show on the monitor and how they change during transport, because that's going to tell if our patient is in a respiratory alkalosis or acidotic state. So for the advanced EMTs and paramedics in the room, you guys should have an understanding of what respiratory alkalosis and respiratory acidosis actually means. And I'll cover more of that here in a little bit when we start talking about our numbers. And again, at any time, feel free to stop me if you have any questions. You want me to go a little more in detail on something, and we can definitely do so. But I'm hoping people will start asking some questions. All right, so capnography in the intubated patient. So this verifies and documents ET2 placement, whether you're in an interfacility role taking a patient on a vent, to a patient who has a trach with a home ventilator, to a cardiac arrest where patients are intubated and or a supraglottic airway is placed. It verifies the placements that are there. It immediately detects changes in end tidal tube position. It assesses effectiveness of chest compressions. I think we've hit that pretty hard already. And the earliest indication of ROSC. Like I mentioned before, you're going to see that change in readings of end tidal spiking prior to getting pulses. The indicator of probability of successful resuscitation, it also allows crews to adjust manual ventilations in accordance with the patient's needs. So we're going to talk about vasodilation, vasoconstriction, and head trauma, hemorrhagic strokes, things like that, where this can make a huge difference in patient outcome. The old days of hyperventilate a patient is gone. We need to look at whether we need to hyper or hypoventilate depending on current status of end tidal CO2 readings. And we'll get into that here in a little bit. So I'm going to look at this here. I'm just going to circle this number really quick. This date, May of 2005. A 2005 study compared field intubations that used capnography to confirm ETT placement versus intubations that did not use capnography to confirm placement. The study showed that 0% of the intubations went unrecognized if misplaced when end tidal CO2 monitoring was used. 0%. Either we knew we were in or we were not in. We didn't leave it in place. 23% went unrecognized in the non-end tidal CO2 monitored group. 23% of the patients were intubated into the stomach, down the esophagus. Therefore, they thought they were in. They didn't use the other methods of confirmation, but the gold standard is end tidal CO2 monitoring. And these patients then, this is why we confirm intubations with waveform capnography, because now we take that patient, we intubate them, we put it in their esophagus, we're transporting down the road for 25, 30 minutes to the hospital, and all we're doing is ventilating the stomach, causing more gastric distension. Gastric distension then pushes up on the thoracic cavity, making it harder to do compressions, and the increased pressure in the thoracic cavity makes it harder for the heart to pump. So now you're doing compressions on a air-filled stomach that is just pushing that thoracic cavity up. Therefore, you're not going to get effective compressions, and it's just not going to work to your needs. All right. This is why it's so important that we have this to recognize, hey, this is not the right hole. We need to make sure we re-intubate these patients. We also want to make sure that we're also not over-ventilating our patients as well, causing that significant gastric distension. And if there's any paramedics in the room, whether the patient's in cardiac arrest or you RSI them and intubate them, things like that, if you're ventilating a patient, put an OG tube in and relieve that gastric distension that's there. All right, so capnography in the non-intubated patients. And this is where the biggest thing comes into play. This is all of us that are in the room from EMT to paramedic level that's using waveform capnography, and we can't intubate. This is the rest of these patients now. So this assists in the assessment of acute respiratory disorders, asthma, COPD, among many others that are there, ARDS, RSV, all these different other respiratory conditions that we can mention. This helps determine how we're going to treat our patients. It also helps with a response to our treatments if we're giving meds en route. It also contributes to that formation of that field diagnosis, right? Looking at our differentials and helps with the field diagnosis and what are we going to do for treatment plans at this point in time. We can also look at using these here and estimate the severity of the condition in the that leads to hypoventilation, stroke, head injury, ETOH intoxication, drug overdose, diabetic ketoacidosis patients, congestive heart failure, analgesia and sedation medications. Medics, very important for this. We're giving pain meds. We can knock patients out with it, so if we give too much, we need to monitor them. All right. Great for assessing perfusion status of these patients as well, right? So like stroke, head injuries, and the patient breathing appropriately. One of the things with stroke patients, or they have a head trauma with a, let's say a TBI, traumatic brain injury, and they have a significant bleeding, whether it be an epidural, subdural, subarachnoid bleed in the brain, right? If it's bleeding, it continues to bleed, right? So how are we going to be able to measure this kind of stuff? Well, we don't know how much pressure is in the brain, right? We don't have the ability to measure that unless you're doing critical care transport. So if we're looking at our end tidal readings, all right, if our end tidal readings are elevated, okay, so our goal for head trauma patients, we want to keep that right around 35. We want to keep that on the lower end, okay? If we start seeing higher readings, so greater than 45, right, our vessels, because are starting to dilate in the brain. Carbon dioxide is a very, very potent vasodilator, right? So if we're ventilating a patient, or we put them on end tidal, and they have head trauma, and their end tidal is 50, all right. At that point in time, we have significant vasodilation. Now, if our end tidal drops below 35, and it starts going less than 35 here, okay, going down here, now we start seeing vasoconstriction. Well, that's a good thing. We're slowing down the bleed, right? However, if we vasoconstrict too much, what is the brain not getting now at this point in time? Everybody should be saying oxygen. Blood transports oxygen. So if we vasoconstrict, now we're not oxygenating the brain. Our brain has to have three things to stay alive. One is oxygen, two is sugar, and three is blood. If you take one of those away, the brain dies, the body dies, right? So we got to make sure we look at those numbers based upon our ventilation status. If a patient's end tidal reading is too high, they're very acidotic. If their end tidal readings are too low, they're very alkalotic. If their end tidal readings are too low, they're vasoconstricted. If their end tidal readings are too high, they're vasodilated. Okay. Hopefully I didn't lose anybody on that. That's why I keep repeating myself over and over again. So when we deal with head injury patients, we really want to look at that number right around 35. That's a perfect number for us to kind of sit at. A little bit on the lower end, so they're not bleeding too much, but we're not really constricting too much as well. We got to kind of fit that point. Now, if the patient readings are starting to elevate, getting to this point here, okay, we want to breathe faster. Breathing faster will bring down that number, therefore causing vasoconstriction. If this number is dropping too low, then you got to slow your breathing down a little bit. So that way it starts climbing back up to a normal range, right? So we're either going to hyper or hypoventilate. There's really no true answer. It's going to be based upon the reading that we currently have. That's the kind of spiel on head trauma, right? Obviously, drug overdose, we can look at our different toxidromes that are out there, whether it be cholinergic, anticholinergic, tricyclics. And we'll do a toxicology lecture later on within the year. I have that plan for toxicology, but it could be a different overdose. We're looking at the different perfusion changes that are there. Diabetic ketoacidosis patients, obviously, they're very acidic, right? And that's why they go into Kussmaul respiration to hopefully blow off a lot of that acid. They're starting to hyperventilate a little bit more, right? If they're hyperventilating and they're too acidotic, their end tidal readings are probably going to be a little bit higher. So they're going to try to breathe fast, and they start in that regular pattern, and in turn, and hope to blow off some of that acid and bring their rate back down again. Right? These patients here, though, there's not much we're going to be able to do in the field for them, other than as a paramedic or advanced EMT, you're going to give a little bit of fluid, because at this point in time, they're probably significantly dehydrated. And we're going to give them some fluid replenishment for that to treat it. But in all, they're going to end up in a hospital receiving insulin and things like that. Obviously, congestive heart failure, we look at CHF, right? That's basically like internal drowning. The alveoli are no longer going to have good gas exchange because there's too much fluid around that. We got to get that fluid out. and we can utilize nitrates and CPAP or BiPAP if you're a medic to help kind of get rid of some of this fluid that's currently there. And obviously analgesia and sedation medications, sedation being more along the lines of combative patient stuff. And there's a lot of different sedative medications that are out there, from Valium to Versed, Ativan, ketamine, a lot of different things that can be Haldol is another one too, depending on what state you work in and what medications you have at your disposal. Every pain med works a little bit different. You have ketamine, fentanyl, Versed, not Versed, fentanyl, morphine, hydromorphone, which is Dilaudid, and things like that for analgesia. So kind of went a little more in detail on that kind of stuff that's there, but again, this is why we need to start utilizing our end-tidal readings to help with our perfusion and oxygenation status. All right, so end-tidal CO2 monitoring reflects changes in ventilation, movement of air in and out of the lungs. It looks at diffusion, the exchange of gas between the air-filled alveoli and the pulmonary circulation. Remember that diffusion is a gas from area of higher to lower to higher concentration. Higher to lower concentration. Sorry, we'll look at that here in the next slide. And then perfusion status, obviously looking at circulation of the blood, right? So we're going to see a lot of our changes that will be there. Because if a patient is breathing fast and become tachypnic, right, we're going to have lower reading. Therefore, we're going to have poor perfusion, and then in turn will cause tachycardia, and our heart will start pumping faster to help move oxygen throughout the system, and our breathing will go faster, therefore dropping our end-tidal down, putting us in a more alkalotic state, and more respiratory alkalosis. Right? So what's occurring in the lungs? I just mentioned a whole bunch of stuff. So this is what's actually happening, right? We have a right ventricle. This is an artery. This is the pulmonary artery coming in, right? This is taking carbon dioxide here, and it's going to take through diffusion, push it into the alveoli. Let's keep doing that. It's going to push it into the alveoli, and then as air comes in for ventilation, right, the inhalation phase, oxygen will then be dumped off through the alveoli into the bloodstream again, becoming oxygenated, going through the pulmonary vein into the left atrium, and then, as you know about the drop of blood, which we talked about earlier, then pushes it back out, right? Another point of interest as well is that our carbon dioxide end-tidal here is in the alveoli. Once you leave the alveoli here, headed back out, all the way to the oro and nasopharynx, to the nose and the mouth, that is all considered dead space. From the alveoli here, from this point up, is all going to be dead space that we need to consider. All right. And we'll talk about dead space and if it's traps and rebreathing later on, and we'll look at the different waveform capnography waveforms for that. But this is perfusion, right? We got to measure that perfusion status, right? Carbon dioxide out, oxygen in, transports around the body, causing a higher or better perfusion. Right, so a little more A and P again. The right ventricle of the heart pumps blood into the pulmonary artery. Remember, the pulmonary artery is the only artery that carries deoxygenated blood. When in the lungs, the blood will then dump carbon dioxide off where it will be diffused into the alveoli. In return, the alveoli will push O2, oxygen, to the into the blood, oxygenating the blood. The pulmonary vein, the only vein that carries sorry about that. The only vein that carries oxygenated blood then takes the newly oxygenated blood back to the heart, specifically into the left atrium. And if you look at the diagram again, you can kind of see where things are going. Remember that all that diffusion, all that gas exchange is happening at the alveolar level, and then the rest of it just kind of pushes it all through, right? So you can see that if we have an obstruction somewhere, whether it be COPD, exacerbation, asthmatics, anaphylaxis, septic shock, all these different things that can cause a patient to not be able to function appropriately and get that oxygen that they need, right? Really hinders this process in here. And if we hinder that process, we need to make sure we act fast and provide the appropriate treatments, whether it be nitrates to bronchodilators to corticosteroids to smooth muscle relaxers like magnesium. There's a lot of different things that we need to look at as far as the treatment goes. Okay, like I said, we'll talk more about those here in a little bit. Right. So how does CO2 get to the alveoli? It's done through perfusion. Right. greater to lesser concentration. It's got to push through that barrier. All right, that's kind of the end all be all with that. Right. The pulmonary vein then picks up the oxygen from the alveoli and then carries it back to the heart. Remember, diffusion is a gas. Osmosis is a liquid, right? So we're looking at diffusion. It diffuses appropriately, greater to lesser concentration, pushes it out, exhalation. Inhalation brings back that oxygen again, and then we start that whole process over, right? So now carbon dioxide is exhaled, and we can capture it via the capnography filter line. And now we can see our true readings and tell this patient's in an alkalotic or acidotic state. And then what we need to do is fix it with ventilation and oxygenation. All right. Any questions so far before we start getting into changes? Please ask questions. Can everybody hear me okay?
We can hear you over here.
All right. You guys have any questions at all?
No questions over here.
Perfect. All right. Excellent. So again, feel free to stop me. If I'm getting too in depth, say, hey, back down a little bit. Or if you want me to explain something a little more in detail, just let me know. And we'll continue on. All right, so changes in end tidal levels. Let's go into this stuff here. Let's dig deep. So why does end tidal CO2 levels decrease? Well, there's a lot of reasons why it could. Decreased cardiac output. So let's talk about cardiac output, right? What types of shock have decreased cardiac output? Cardiogenic. We'll start with that one there. Cardiogenic shock has decreased cardiac output. Anaphylactic shock rate, decreased cardiac output. The only shock that's out there that has an increased cardiac output is septic shock. That is the only one. Everything else is the decreased cardiac output. All right. Other things looking for would be cardiac arrest, pulmonary embolus, or PE. PEs can sit many different places, but the worst PE you can get is what they call a saddle PE. That kind of sits right in the middle like a saddle, and it really blocks a lot of that flow. We'll talk about PE changes here in a little bit and see. We'll talk about different numbers. Bronchospasms. That's our bronchoconstriction. Our bronchioles are spasming. They're becoming more constricted. Therefore, we're not getting good passage of air. Decreased muscular activity and hypothermia is the other one as well. We're going to start seeing that. Now, whether you be from the north or the south, hypothermia can happen. Our bodies run at 98.6 degrees. That's the normal textbook answer. If our body temperature drops to 82 degrees, we're in stage 4 hypothermia. These patients are not going to be well. They're going to be pretty much unresponsive. Their heart rates are going to pretty much be non-existent at 82 degrees. Right? So these patients here require different oxygenation of them, what we can provide for them. So Peter, for your protocols up there, you have, if you're within an hour of an ECMO center, for you would be Portsmouth Hospital. That's where the patient really needs to go if they're that cold for hypothermia. This is not a hypothermia class, but I kind of want to make a mention of that. They need ECMO to help oxygenate. So again, hypothermia, can you see a lot of changes? All right, go ahead. I see your hands up.
So Maine Med doesn't have that?
They do, but your closest one is going to be Portsmouth Hospital.
Yeah, it's kind of a toss up. Well, between the two of them, depending on where we are up here, so.
That's true.
Yeah.
You got to think of your straight shots.
Right.
So
yeah, Portsmouth is a straight shot, so.
it is.
Yeah.
So that's just something to think about too, but it has to be within an hour. Up here, or I should say down here, a lot of your major hospitals have ECMO. So Richland has it. I believe Lexington has it. Your Augusta hospitals have it down there as well for Georgia. So again, there's different things that we know hypothermia. That's kind of off topic. We can talk about that in a hypothermia class sometime, but it's just there. Just kind of think of the reason why end tidal CO2 levels actually do decrease. So again, why do they increase? Why do they go back up? Well, increased cardiac output. So good compressions during cardiac arrest will help it go up higher. Increased muscular activity like shivering. effective therapy from bronchospasm. So we're giving our bronchodilators, right? So we're going to start seeing those trends. Right? But also, again, bradypnea will actually start increasing it too. So you may have a higher number for patients who have an opiate overdose and they're breathing 4 or 5 times a minute. It could be higher to start, and then eventually it'll start changing over, right? So the anatomy of a waveform. So now I've brought up a couple of those different things that are back there. And again, we're going to break them down even more through this presentation. Let's talk about what it actually means. We'll go through the different phases. So the height of the height shows amount of carbon dioxide that's exhaled. Exhaled, right? So the higher it is, the more acidic the patient is. Okay. Remember, between 35 and 45 are our normal ranges. If you ask a respiratory therapist, they're going to tell you absolute normal is going to be 40, right? The only time you go a little bit lower than that is going to be for our head trauma patients. All right, the length shows the time. So time being here, from this end to this end, right? And then the height represents alkalosis or acidosis and how much acid is being retained and or blown off. This represents the normal waveform, one cycle. So this is one breath here. So let's break it down even more than that. Phase one is that green line that you can see. It is a baseline for waveform. The initial upstroke of the waveform represents the exhaled gas from the upper airways, right? AKA anatomical dead space, right? It needs to be 0. There's nothing in our air in our dead space. And I'll show you that in the next slide. All right, exhalation begins. Many reverse this and believe that this begins inhalation, but it is not. Inhalation is here. That downstroke we'll talk about here in a few minutes. So phase one, dead space. So dead space begins exhalation. CO2 is absent at that point, and air is coming from the mouth, nose, and pharynx. Gas exchange does not occur here. So from this point right here, all the way down into the lungs and to the point where the alveoli start is all going to be dead space. Roughly about 150 mLs of air. Right? So ventilated areas that do not take part in the exchanging of gases. So like I mentioned before, airways leading to the alveoli and ventilated areas in the lungs without blood flow. It is blood flow. That's not dead space. Dead space is anything that's hollow and open. That doesn't involve the actual change of gas. Right? So phase two is a transition from the upper to lower airway ventilation, as you can see in the blue here. Shows changes in perfusion status of a patient. CO2 present and increasing in exhaled air. So phase two, remember phase one down here, we're starting that upstroke going up into phase two. And within phase two, CO2 from the alveoli reaches the upper airway and mixes with the dead space air. So why you see a rise in CO2? CO2 is now detectable in the exhaled air via capnography, right? So here's our, let's circle the alveoli here, okay? Perfusion's happening. From this point forward, that is all dead space. So it's either going to be oxygen coming in, or it's going to be end-tidal, or sorry, CO2 coming out at that point, going into the 150 mLs of air roughly to get up to this point for exhalation or inhalation. Then we start seeing it being detectable. Phase three shows the alveolar gas exchange. Okay, that's phase three here, the yellow line. It's what we call the plateau. So this indicates changes in gas distribution. So increases in this slope indicates problems with distribution of gas delivery, right? So this is a normal breakdown of a waveform. We're going to get into the problems with distribution here in a little bit. I just don't want to go too much in depth on that yet. Right, so CO2 now makes up the majority of the exhaled air, and the concentration of the CO2 remains fairly constant from the alveoli to the nose and mouth at this phase. It's constant. There's nothing blocking it. There's no mucus, there's no constriction, nothing is blocking this stuff from happening at this point in time. This is your end tidal. Like I mentioned here, the star marks the end tidal wave. So the end of exhalation contains the highest concentration of carbon dioxide, which is why we call it EtCO2, end-tidal CO2. So that's our reading. That's our number. 35 to 45. That's our normal range, right? So for your advanced EMTs and paramedics, this is a very good number to memorize if you don't already know it. You should know it. This is going to help with acid-base balance and how we're going to treat things. Right. All right. So phase 4, beginning of the inhalation, is our descending phase. Inspiratory downstroke returns to 0 or baseline. This should be 0. If we're retaining CO2 or rebreathing, we'll have a higher number. We'll get into that here in a little bit, right? CO2 levels drop to baseline 0. Oxygen is now in the airway. It's coming back in. So therefore, it's not going to pick it up. We're going to depend on our SpO2 for that point to make sure we're oxygenating appropriately. So what is the normal range for capnography waveform? Someone give me a number. What's our normal range? Who can jump in? Put it in the chat box if you want. Doesn't really matter. Just someone give me an answer. What do we got?
You're right.
What was that?
Is that the 35, 45? What's the
It is.
Yeah.
100% correct. Yes, 35 to 45. Exactly. And there you go. Normal range. Perfect. Don't forget those numbers. They're very important. Right? So we know 35 to 45 is normal. Okay. We're not RTs. We use 35 to 45. Right? End-tidal CO2 less than 35 is hyperventilation, or what they call hypocapnia. Hypocapnia meaning low carbon dioxide. Okay. So as you look at the duration here, we're going to have shorter duration, shorter height, and you're going to have more breaths per minute. Okay. So they're hyperventilating, which makes them alkalotic and hypocapnic. So low carbon dioxide makes them alkalotic, caused by hyperventilation. Greater than 45 is hypoventilation, hypercapnic. So they have high carbon dioxide. Your post-cardiac arrest patients with ROSC is one of them. You're going to have that big spike because they've been dead for so long that their body starts waking up. I shouldn't say waking up. The body starts getting a pulse back. They start perfusing, right? And if they start perfusing, all that acid is going to get dumped. And you're going to have a really high spike in end tidal. I've seen it as high as like 100 before in cardiac arrest with ROSC, right? Eventually that will come back down again. You just have to give it time. Don't start treating that right away and say, oh my God, we need to hyperventilate this patient. Breathe normal. The body just came out of a cardiac arrest for 20 minutes, right? Give it a minute for it to normalize off, right? It can't happen that quick, right? So with hypoventilation, back to this one here, you're going to have longer duration, right? With a higher height, right? So again, we'll go back to this low one here. Hyperventilation, short duration, right? Height of waveform is going to be lower, and it's going to be frequency is going to be faster. The hypoventilation, your duration is longer, elevated, right? But your frequency is going to be slower. Right? Here we go. How would your waveform change if you intentionally started to breathe at a rate of 40? Who can give me those answers? Frequency, duration, and height. Anybody want to take a stab at that?
If they're breathing too much, wouldn't it be kind of like all over the place?
So if you're breathing at 40 times a minute, is that too fast or too slow?
Too fast.
Okay. So if you're hyperventilating a patient, would you expect the frequency of the waveform to be more or less?
More.
More. 100% correct. More.
More.
What about the duration of waveform?
Be smaller, wouldn't it?
It'd be shorter. Correct. And the height would be
Yes.
taller or shorter?
If they're hyperventilating, it'd be
Yep.
higher, right?
Nope. Other one. You got a 50-50 shot at that one. It'd be lower. All right.
Okay.
So as you can see here, normal being 45 right here, in that line 45, it's going to be lower. As you can see, it's going to be faster in duration. Sorry, faster in frequency And you notice the difference here between the duration. It's going to be shorter. That's hyperventilation. All right, let's try something new. Hyperventilation waveform indicates CO2 deficiency. Hyperventilation, decreased pulmonary perfusion, hypothermia, and decreased metabolism. So what do we need to do to fix that? One, we got to fix the rate. They're hyperventilating. And a patient that is conscious and alert and orientated, breathing at 50 times a minute, right? Put a BVM on their face and breathe for them. Control that respiratory drive. Get them to come back down again, right? So every time a patient takes a breath in, the best you can, give them a little bit of oxygen. Squeeze that bag. Control that rate. Bring that rate back down again if they need it, right? So adjust that ventilation rate. Decrease pulmonary perfusion. Well, evaluate for adequate sedation, right? There's more patients that are intubated too. Hypothermia, right? Again, we need to warm them back up. We also need to evaluate for anxiety and also conserve body heat. The patient needs to be kept warm. All right, perfect. So how would your waveform change if you intentionally decreased your respiratory rate to 10? How would that change? Frequency, duration, and height. Remember, we're hypoventilating now.
Hypo is what, higher?
Yep, height will be higher. Correct, so higher than 45.
It's going to be longer.
Yep, duration is going to be longer.
You'll have those tombstones that you're looking for.
Yeah, those big ones, yeah. And then the frequency would be faster or slower?
Lower?
Slower, yeah. Rate's 10. Perfect. Good job.
Oh, and Tim says hi.
Hello.
Tim Ringer.
All right, so hi, Tim. So hypoventilation. So as we look at this right here, normal being normal here, you can see that duration is a lot longer now. The height is going to be a lot higher, and the frequency is going to be slower. Right. So if they're hypoventilating, well, how do we fix that? We start adjusting the ventilatory rate, make them breathe a little bit faster. Right. Respiratory depressant drugs can cause this. Would indicate this. So decrease respiratory depressant drug dosaging. And also increase metabolism, so maintain normal body temperature. Once again, we have to make sure we're looking at body temps. Right? So if the patient's on a ventilator, we can make our rate changes. Right? Change our rate a little bit. Now we've learned three different waveforms now. We looked at our normal, our hyperventilation, and our hypoventilation. So learning cardiac rhythms, right? Keep practicing looking at these. We've taught you three different ones. Let's add another one into the mix. So what do you think is happening here? When you look at this picture, what do you think? Right? Let's break it down a little bit too.
People breathe and then they stop.
Well,
like a sleep apnea patient, maybe.
Yeah, not necessarily sleep apnea. What are you seeing here? Is that normal? Does it come up like this and then plateau off? Or is that rounded?
Yeah, rounded.
Right. So it's rounded here. And then they take their breath back in. Then they exhale, it's rounded again. So what's happening here is that we're starting to see bronchoconstriction. So our alveoli are trying to release all at the same time, right? That's a normal ventilation, normal waveform. But if there's mucus in the way, there's blockages, it's not going to escape all at the same time, therefore causing that rounded edge, or it looks like the shark fin. Okay. So in documentation, when you're documenting this kind of waveform in your narratives and things like that, don't put down shark fin. That's not the true terminology for it. The true terminology is bronchospasm or bronchoconstrictive waveform, right? So this is restrictive, proper ventilation. The alveoli unevenly fill during inspiration, and then they also empty unevenly during expiration, which causes that rounded shape, that shark fin. Uneven air flow then during exhalation dilutes the exhaled carbon dioxide. This alters the ascending phase of the plateau, slower rise in carbon dioxide concentration, and that characteristic pattern for the bronchospasm. Right? So how do we fix this? Bronchodilators. Open the airway back up. Let's get those bronchioles dilated, allow for better gas exchange, and in turn, you're hoping to start seeing it come back up and then plateau off and get rid of that rounded edge that's there. And we'll start seeing that change with the medication. That's why it's so important that we get pre and post everything that we do. It's kind of like doing a 12 lead. Before you start popping nitrates into a patient and treating for ACS, you want to get a 12 lead pre and post to know that your medication regimen is working for this patient during transport. Right? If I have nothing to go by, then how do I know it's working? Right? How do I know that's working there? So that's what we need to look for. We got to get pre and post and continuous. And remember, all this stuff here saves. And if you upload it to your cardiac monitor, to your run report, everything should be uploading into it. So now I've added that fourth one into the mix. So now we've learned normal, hyper and hypoventilation, and bronchospasms or bronchoconstrictive waveform. Any questions at this point? I'm not going to, if you guys need a break, just get up and take a break if you need to. I'm just going to keep going so we can make this 2 hours. Right. We're about halfway done. So, all right. So let's move into capnography and the advanced airway. So we talked about advanced airways, intubation, being the biggest one here, the gold standard of securing an airway. But again, we can use waveform capnography on BVM. So if you got a cardiac arrest and you put a waveform chimney in between your mask and your BVM, you can actually still get readings. The drawback with that is once you take it off the patient, it doesn't read anymore. So you got to leave the mask on the patient during CPR, right? But an OPA or NPA can be in place. You can still get readings to kind of figure out where you are at that point in time. But once you start placing your Kings or your iGels, things like that, that's where you are going to get that waveform capnography going. Right? Usually confirm that your tube is in place. Remember that improper placement of the tube will result in a lack of a waveform. So you're not going to have this, right? It'll just be that flat line straight across. When you start seeing waveform, the tube is now confirmed. Okay. So again, for medical legal, capnography provides documentation for placement, ongoing documentation over time throughout the trending printout, and documentation of the correct position at the ED arrival, right? When I first started EMS, I saw doctors take out intubation tubes so they could do it themselves, so they didn't believe you were actually in. Then they would probably miss themselves too, and then they had a poor outcome, right? So again, this shows it's in. The monitor is not going to lie. Carbon dioxide is going to come out. It's going to give a reading. You confirm that you're in the airway, right? Your stomach's not going to produce carbon dioxide. It's rare. In rare cases where someone truly overdoses, and I'm talking about truly overdoses on antacids, you might get a false reading. Other than that, and again, that's very rare that ever happens, and you get that false reading. If you have carbon dioxide being exhaled, you're in the trachea. Right. Tube dislodgement, we talked about that earlier, where you're getting great ventilations, and then you move that patient from the floor to the bed or the bed to the other bed. Next thing you know, the apneic alarm goes off, you're ventilating, the tube probably just came out. Right? So be prepared to reintubate this patient. So this waveform here is what they call a dislodged tube waveform. We have a good waveform here, and then it's just gone. Right? So it's another one you guys can add to your arsenal of different waveforms to pick up on. Right? This is only provided through the use of capnography. Right? Other than that, if it comes dislodged and you don't have capnography present, you're never going to know it's been dislodged. You're just going to ventilate one breath every 6 seconds for 6 to 8 seconds while CPR is being done, and then all you're doing is ventilating the oropharynx. It's not going to do any good. So you need to make sure you have that continuous waveform. Right? So again, if it drops off like this here, right, and your value drops down to 0, within 30 seconds, your cardiac monitor will start alarming. So when you guys start shutting off alarms on your cardiac monitor, so you don't like the recalibration SPO2 thing that's on there, right? You're disabling all your alarms. Therefore, your apneic alarm will probably go off, but it'll just blink a light and you won't even know what's going on, right? So keep that kind of stuff in mind. And as I was making this presentation, I kind of want to point out, we're talking about end tidal placements and all that kind of stuff here. My reference was 1983. Waveform capnography has been around for a very long time. It just so happens right around 2006, 2005, it became introduced more into the EMS world, unfortunately. So can it assist with CPR? Everybody should be saying yes, absolutely. Determination of how effective your chest compressions are. It helps show early detection of ROSC. It provides data for the decision to cease resuscitation. So you look at it again, so if we have a patient in cardiac arrest and they're asystolic for 20 minutes, we need to call it in the field, right? If their end tidal is 0 and their heart rate is 0, and you confirm in 3 different leads that they're asystole, the patient is deceased. They are dead. We can do time of death. We can call it there, right? It's one other thing we can utilize to help with this. Provides data for the decision, right? So the end tidal reading remains under 10 for over 20 minutes of a working code. The chances, again, of getting ROSC are very, very slim at that point, right? So capnography and the CPR assessment. So when a patient is in cardiac arrest, remember that the end tidal CO2 is going to be low, right? The patient is not perfusing enough, therefore gas exchange is not occurring appropriately. In cardiac arrest, we are hoping to keep the end tidal around 10 to 15. Without a number this high, the chances of getting ROSC are very low at this point, right? So you can increase the end tidal CO2 by providing better chest compressions, right? Thus providing better perfusion to the alveoli during CPR. This is why we have to look at that team-focused CPR when we're doing this kind of stuff. So we rotate out every 2 minutes. I don't care how strong and tough you are. After 2 minutes, you start becoming less effective. This is why mechanical CPR is a gold standard out there, because it provides great compressions, right? So going back to that perfusion one again, if we can't have diffusion, we can't move those gases around, right? The body cannot perfuse appropriately. Without going into detail on this slide, right? If your capnography wave is low during your next code, compress harder and faster, and you'll start seeing that change, right? So you guys at Jackson First Alert, you guys have a Lucas device. If you go to that cardiac arrest, you have end tidal on there. Just keep in mind, hey, what did Kevin say before about this? Look at it, right? Because obviously you're going to start compressions manually, and you're going to switch over to your Lucas device. If you have end tidal out fast enough, you can see the change. You'll see a difference, right? You need good perfusion, right? So let's go back a couple of years. In 1978, a scientist reported a decrease in end tidal CO2 as a person performing CPR fatigued, followed by an increase in end tidal CO2 when a new rescuer took over, presumably providing better chest compressions. In 1978, they made this discovery, right? This was published again in 2004. Why did it take so long for us to work on team-focused CPR? Good question to ask, right? Another study suggests reductions in end tidal during CPR are associated with comparable reductions in cardiac output. The extent to which resuscitation maneuvers, especially precordial compression, maintains cardiac output may be more readily assessed by measurement of end tidal than palpitation of an arterial pulse. Yeah, it's old, but it still applies today. Underline here, November of 1985. For those of you who've been in EMS for 20 plus years, think about when end tidal CO2 was first brought to your state. Just think about that. You don't have to tell me over this presentation. Just think about when it was brought in, and look at these dates here now of how long it's been going on pre-hospitally. I'm sorry, going on in the hospital, not pre-hospitally. All right, just kind of think about that for a minute. So with the new American Heart Association guidelines calling for quality compressions, push hard, push fast, push deep, rescuers will switch places every 2 minutes. You've hit that pretty hard on CPR classes, team focus CPR, rotating out. You should be setting the monitor up so that the compressors can view end tidal CO2 readings as well as EKG waveform generated by their compression, right? With all the technology that's out there today, it tells us how deep we're pushing, to end tidal readings, to rhythm strips. I mean, it's endless of the things that they are now readily available for us. We encourage you to keep the end tidal number as high as possible during CPR, right? As high as possible. So if you're doing compressions and you're seeing compressions being done and you see this all of a sudden, and then it stays that way, right? What does that mean? What would that mean to you? Oop. Right, CPR here. Keep going, keep going. Sudden spike in end tidal. What would that indicate to you guys?
Back there?
What was that?
Ross back?
Yeah, you're starting to get pulses back. The patient's starting to perfuse now. The body finally started back up again and dumped off all that acid that's been sitting here because you can't compress as hard as that heart can pump. So once you started getting full body perfusion, all that acid is now released here, right? So this is a sign of ROSC. Why does it look that way? Because I just mentioned before that retention of CO2. The wave is now large because the patient in cardiac arrest has now been retaining CO2 for so long and just dumped everything off. Now, because all of a sudden they got pulses back. This exhalation is retained CO2, what gives the box such a high appearance. Remember that the box is representation of an actual figure. In this case, the end tidal CO2 number is about 60, right? It's okay. That's a good thing that you see that. So keep ventilating the patient, okay? Keep breathing for them. Run all your ROSC treatments from 12 leads to meds to pressors, whatever needs to be done to keep this patient alive and a heartbeat going. This will eventually normal off. Eventually, you just have to give it time, right? So survived to discharge from hospital. The average end tidal was 30. Okay, non-survivor between 4 and 10. So if you get to a cardiac arrest and it's, like I said, greater than 10, but the average is about 30 throughout your whole entire cardiac arrest, the chances of them walking out of the hospital are very, very high. Unless there's something else that happened with it. All right. Let's move into increased intracranial pressure, ICP, and then capnography. Okay. First of all, before getting into capnography, increased cranial pressure can happen with head bleeds, right? How do you know you have super increased intracranial pressure? What are the 3 things we look for? Remember, this is no longer cardiac arrest. These are our conscious patients. What are 3 things we look for?
Does the blood pressure go down, Kevin?
Not necessarily down. You're going to start seeing widened pressures, right? So you start seeing some hypertension. What else? There's 2 more things.
Is that the halo effect?
Nope. The halo effect would be if you had any kind of leakage. So cerebrospinal fluid coming out. So I'm going to put HTN plus.
Increased heart rate,
I heard decreased heart rate.
increased heart rate.
Yeah. So bradycardia, decreased heart rate. And then the last one. That's a plus, I promise. Irregular respirations is the last one. So hypertension or that widening pulse pressure, bradycardia, irregular respirations, what they call Cushing's triad. Cushing's triad is significantly increased ICP. So if you have those 3 things and the patient's unresponsive or semi-responsive, start thinking of significant increased cranial pressure. Now, again, if it's a bleed, we can kind of hopefully, we can't fix it, but hopefully we can control the blood flow to the brain, looking at our end tidal numbers. So ICP and end tidal. So capnography should be also utilized in patients with ICP issues. The following ICP patients are very sensitive to fluctuations in end tidal: stroke, possible bleeds, trauma to the head, brain tumors, and brain infections. Right? So what do you think will occur to cerebral vasculature if the patient has high end tidal? Remember I mentioned earlier that carbon dioxide is a very, very potent what? Vasoconstrictor or vasodilator?
Dilator.
Yes. So the patient has high levels of carbon dioxide. The good is that it increases cerebral blood flow to counter that cerebral hypoxia. The bad is that increased cerebral blood flow increases ICP, which may increase brain edema, therefore causing herniation. And if your brainstem herniates, the patient's dead. Or it can cause hemispheric shift if there's a lot of blood. What I mean by that is that we have bleeding here to the brain, okay, pushing down. This would be your epidural bleed. It looks like it doesn't look like a moon shape. It's just pressure coming down. So you have an epidural bleed coming in. We can talk about more about different head bleeds in a TBI lecture we can do later, right? So we have pressure pushing down in.
That was my meatloaf. Yeah.
Right? Therefore, the higher the pressure, the more the bleed. Let's just say I drew a line right down the middle like this. That didn't work. Like this, right down the middle, okay? This right here that you're seeing here should be centered. So if there's pressure pushing on the brain causing shift this way, this is what we call hemispheric shift. We have the right and left hemisphere, okay? One here, one here. And if one shifts over because of pressure, that's bad. That's significant increased cranial pressure to the point where the brainstem can actually herniate depending on how much blood is being pushed into that brain. Okay, so that's kind of something to kind of keep in mind. So there is some good to this because we want to counter that cerebral hypoxia. But again, if we do too much, will cause hemispheric shift or brainstem herniation. Right. So we got to make sure we look for that magic number. And like I mentioned before, 35. That's a 5, I promise. 35 is the number we want to look for. Okay. If it starts getting higher than that, bring it back down a little bit. If you get down to 32, there's still nothing really wrong with that either. If you start getting into the teens and like mid 20s, then we need to start at that point in time hypoventilating the patient to get that back up a little bit more. Okay. So moving to the next slide here, what do you think will occur to cerebral vasculature if the patient has low carbon dioxide levels? We said vasodilation for the other one, so obviously it'd be vasoconstriction, right? So low CO2 levels lead to cerebral vasoconstriction. The good is that it lowers the carbon dioxide levels that can cause mild cerebral vasoconstriction, which will decrease the ICP. Although low CO2 levels decrease ICP, but it may also cause cerebral hypoxia. One of those things that actually kills the brain. So we got to make sure that's why I said 35 is that magic number. So looking at the pearls from this, and we'll go into some treatment goals here in a second. Hypoventilation increases CO2 levels, not blowing off the CO2 results in cerebral vasodilation. Hyperventilation decreases CO2 levels, blowing off too much CO2 results in vasoconstriction. Again, we want to look at that magic number. So our target goal really should be 35. Okay, I'm going to circle that again. Important numbers to remember. We need to avoid cerebral hypoxia to maintain adequate cerebral blood flow, monitor oxygen saturations with pulse oximetry, utilize capnography in conjunction with pulse oximetry to make sure we're meeting that 35 millimeters of mercury reading. All right. So way back when we were always told, and I'm going back quite a few years, right? We were always told patient with head injuries, hyperventilate. Hyperventilate. It's a great thing. We want to make sure we're hyperventilating these patients. We need to increase that blood flow. Recent evidence suggests hyperventilation leads to ischemia almost immediately. So current models both ischemia and traumatic brain injury. suggests an immediate period during which the brain is especially vulnerable to secondary insults. This underscores the importance of avoiding hyperventilation in the pre-hospital environment. Right? 2004. Right. Any questions on ICP? Hearing nothing, we'll move forward to the dyspneic patient. So dyspnea, shortness of breath. So other patients needing end-tidal monitoring will be COPD or emphysema in your chronic bronchitis patients, asthma, CHF, pulmonary edema, pneumonia, possible PEs, and a cardiac ischemia. Right? So why should we use capnography? To assess and trend your patients' low perfusion, hyper and hypoventilation statuses, and to identify changes in capnography waveforms like the bronchospasm patient and the COPD and asthmatics. So kind of going into the next slide here, we talked about how it produces changes in ascending phase 2 with the loss of that sharp upslope, right? So again, altering plateau 3, producing that shark fin waveform that you see here, right? That's going to be our bronchospasm. So let me bring up the next slide really quick. So normal versus bronchospasm here, we can start seeing that we don't have that high upstroke and then plateau. It starts coming up gradually to that point and then back down again. And we can make those changes here. So our treatments are going to be our bronchodilators, right? So we start off with that first. We do inline nebs if we're putting BiPAP or CPAP on the patient. If we don't, we just use an updraft nebulizer like you can see here. Hopefully with that therapy, we'll start seeing that shark fin or that bronchoconstrictive waveform, start making that change over to a better, more accurate plateau for better gas exchange. If we're not seeing a lot of these changes of the bronchodilation, as a paramedic, you should be considering corticosteroids like dexamethasone or Decadron or like a Solumedrol medication. And if you start seeing patients that are getting close to failure, you can start thinking about smooth muscle relaxants like magnesium sulfate as an administration for that. Just keep in mind that it is a smooth muscle relaxation medication that can be utilized for that purpose of relaxing the smooth muscles, the patient can breathe better. If they're in failure and they've been in respiratory distress significantly for quite some time, like a couple hours, and all they have left is their smooth muscles to stay alive, and you relax those smooth muscles, the patient's going to go into respiratory arrest. Right? So you got to know when to give that mag sulfate, when the best time is going to be. BiPAP and CPAP are phenomenal for these patients as well. And again, we can go into that in a respiratory class and how those work, but you can utilize BiPAP or CPAP and inline nebs of those. So the role of the capnography with COPD is the patients will, the COPD patients, the PaCO2 or the partial pressure of carbon dioxide and the arterial blood gas or arterial gas increases. This is the waveform that you'll probably see. Notice how the ascending phase of the plateau looks abnormal. This is because there's an uneven emptying of gases, as you can see here. So it's zeroed out, comes up, and then it empties differently, uneven, which means it's going to get you a higher reading of end-tidal up here versus the normal 45. Right? So as you can see, this is what they call retention of carbon dioxide. Now, we talked about this before, and I bring this up. If a patient has COPD and their saturations are, let's say, 80%, okay, you can give them high flow oxygen at 15 liters a minute through a non-rebreather. Don't think that you're going to hurt these patients who are COPD or carbon dioxide retainers that live around 90. If they're short of breath and you put their XPO2 to 100% in a short period of time, and I'm talking 24 hours, short period of time, you're not going to hurt this patient. It is not going to hurt them. Now, if you kept them on a non-rebreather for 2 weeks, that's a different story. Okay. But your initial treatments, And again, this was taught years ago, saying, "Oh my God, they're COPD retainers. We can't give them oxygen. We got to hold back. They live at 89, 90%. We got to get rid of that mentality. We can give these patients oxygen. It's okay, right? It's not going to hurt these patients in the short term. So go ahead and give them the oxygen that they truly do need, right? So here's a scenario for you. You had a 70-year-old female, dyspnea with moderate chest pain, has a history of a myocardial infarction and a CABG ×3. Those who don't know what CABG means, is coronary artery bypass graft. On oxygen at 2 liters a minute. The pulse is 60, the BP of 144 over 70. Respiratory rate of 38, labored and shallow. Skin is cool and diaphragmatic with some pedal edema. The initial SpO2 is 79% with an end tidal of 20. What do you want to do?
Gotta give him oxygen.
Yeah, absolutely, right? Nasal cannula, an under breather, CPAP, BiPAP. What do you want to do?
Well, his respirations are at 38. He's at 79 down there, so I need to bring him up. I need to probably control him. So can't we do like probably a CPAP would be best for him?
Yeah, I like that. Medics should be thinking BiPAP with this patient. Okay. What do you think's wrong with him? For her, I should say. I mean, you want to start CPAP or BiPAP? You want to start, giving oxygen. What's your differential? What are you starting to think? We obviously you have a plan in place. You're treating something.
Probably like cardiac. I mean, he had a full blown CABG and stuff like that. His pulse is 60, blood pressure's up, elevated, his
Okay.
respirations are up, and then his SpO2 is down. We got to control that breathing.
Okay. So
Yeah.
so this 38 is causing this low number, right?
Mm-hmm.
Okay. Pedal edema, thinking cardiac at that point.
It could be like, I mean, because you can have that's in the legs. Yeah, I mean, because the blood could be pooling down there, or that could be fluid down there, and yet it's not
Okay.
circulating the blood in his body because of that.
So I'll put this out there, and you're on the right track. If it looks like a duck and quacks like a duck, it's not a zebra. It's CHF. Okay. Look at the history. MI, CABG, already on oxygen, right? Blood pressure is a little elevated. Heart rate is normal. Could be on beta blockers too. This is elevated here. There's pedal edema, so you know the right-sided heart failure. Sats are dropping. End tidal is low. This screams to me like a CHF patient, right? So you are great on giving CPAP. Nothing wrong with that. CPAP will also assist you in lowering their blood pressure because it causes pressure on the thoracic cavity in the lungs. Therefore, the internal will also decrease your blood pressure. You could administer, nitroglycerin tablets. You could look at nitro paste. You could look at nitro drips, depending on the blood pressure of the patient. Again, this is national standard. All right. During transport, you trend your vitals. This is what you see. SpO2 is 99%. End tidal is 35. Right. So you've seen that change. If you didn't put the patient at end tidal prior to that, you never would have seen the trending as you're seeing here. Right. We're starting to see a vast improvement. So you were right. You were on that track of congestive heart failure. This is kind of our treatment plan going forward with this. If you are putting nitrates on a patient or through an IV, you have to have at least one line for nitro tablets, nitro paste. If you're running a nitro drip, then you have to have 2 lines in place. You have to have 2 because nothing you can give is compatible with nitro. If you have to give a second Medicaid, it's more for the paramedics. All right, next one, PEs and capnography. Getting close to the end here. Right, so we have what they call a VQ mismatch or ventilation perfusion mismatch. This is when the amount of ventilation or perfusion is altered. So in a pulmonary embolus, patients, there is a decrease in perfusion when compared to ventilation, right? Because we have a massive clot somewhere in that pulmonary system. blocking perfusion. Okay. This increases the dead space. Remember, the dead space is the part of the airway that is unable to take part in gas exchange due to the lack of perfusion. Right? Therefore, increased dead space happens. The PE patients therefore will show a reduction in exhaled CO2 on your capnography due to the increased dead space. So the green line represents normal, and see how the PE patient is way under it. Low end tidal due to increased dead space. Well, you just mentioned that I mentioned earlier that the patient's hyperventilating, but it's going to drop. This patient may not be hyperventilating, but they're going to have low end tidal because there's a blockage somewhere else. Okay. But they're also going to show the other signs of pulmonary embolus: anxiety, chest pain, sharp pain on inspiration, right? Continuous sharp pain, syncopal episodes, right? Shortness of breath. There's a lot of different indicators that are there for pulmonary embolus other than just looking at your end tidal readings. But it's one more thing that you can utilize on how that's going to work. So I just kind of answered your question on the next slide. Give me some examples of how PE patients present. That's kind of how they would present to you, right? That feeling of doom. They might have some hemoptysis, so vomiting blood, syncope, a sudden decrease in end tidal. They could be running around 35 to 45, and all of a sudden they drop to 18. So a sudden decrease in end tidal readings. This is why it should be utilized to assist in formulating that field diagnosis utilizing our differentials. So on this next slide here, kind of what we just went over: respiratory rate of greater than 20, chest pain, hypoxia, anxiety, syncope, sudden dyspnea, tachycardia. A lot of these things are all there, right? So if you respond to a call for a 25-year-old female, shortness of breath and sharp pain in the chest, right? She's on Chantix and Yasmin. She is healthy with no other issues. For medical history, does this sound like a PE candidate to you guys? There should be. It does to me, and this is why, right? 25-year-old female, shortness of breath and sharp pain in the chest, and takes birth control. I would start thinking PE with a patient like this. I didn't say I'd start treating it as a PE. I would start thinking it. Right? Sounds like it. The potentials are there. Remember that reverse pyramid of differentials, like here? Got that reverse pyramid. Your diagnosis being here. Here's all your differentials up here. And inside this box here are all the different tests that you can utilize to come up with your differential diagnosis down here for treatment. That's kind of the reverse pyramid of differentials. All right? Patient begins to hyperventilate. You place her on capnography and you see this. Okay? Without warning, you see a marked decrease in end tidal and the patient's mental status. So they're alert oriented here, they're hyperventilating with chest pain and all that other wonderful stuff I mentioned. And then all of a sudden they become altered. End tidal drops to 18, right? And then you start seeing pulse oximetry dropping and everything else. Now, are you thinking more of a PE?
Yes.
Yep. Let me go back just for a minute. Look at your medical history. Your sample history is huge. Birth control is one of the leading causes of pulmonary embolus.
I thought that was heart attack though.
Heart attacks can too, right? Recent surgeries. But again, heart attacks not as much. Recent surgeries can happen quite often. Long flights, DVTs can cause pulmonary embolus. Birth control can cause a lot of PEs. That's why you see a lot of patients that are on birth control. They'll take also an aspirin as well. So that way there, it makes those clots less sticky, that platelet aggregator. And then obstetrics is another one. So a patient that delivers a baby has a higher chance of getting a PE after delivery. So just because baby is born, you're focusing on the neonate now, that newborn. You still got to watch mom, keep her on end tidal, and keep an eye on her. If she starts complaining of chest pain, shortness of breath, and decreased end tidal, she probably threw a clot after the pregnancy, after the delivery. Right? So you got to kind of keep those things, look at all your histories and your sample history to kind of figure out your differentials that are there. So what caused the drop in end tidal? Typically, hyperventilation alone does not cause a sudden rapid drop in end tidal. PEs do, because you have that massive clot that just gets in that pulmonary artery and just kind of blocks it, right? The pulmonary vein, pulmonary artery, or if it's a saddle kind of sitting in both. So remember that a PE will increase the dead space of the lung, therefore causing that decrease in end tidal CO2. Then the increase in dead space will produce a decreased exhaled carbon dioxide. Now put the PE signs and symptoms together with the end tidal CO2 information, you just made an excellent field diagnosis, right? Having the tools are nice, but knowing when to use them is key. Knowing when you need to utilize the tools of your trade that you have to come up with your differentials, right? Using capnography in hypoventilatory states. So then, first of all, famous differential diagnosis is that can cause a patient to breathe slow, right? So the patients with altered mental status, like head injury, CVA, drug overdose, heavily sedated, ETOH, sepsis or infection, especially CNS in nature. These are all different differentials you need to think about that can cause a patient to be hypoventilating. And how can we fix that? Which of these, so looking at these A, B, and C, which patient here is hypoventilating?
Is it C?
It is. Yep. So C, that long duration, elevated height, slow frequency. Yep. So E, we took top of that one there. It's above 45. Patients retaining too much carbon dioxide at this point. Here. So what is this patient doing? This patient is actually breathing very shallow, which causes most of the waveforms to be small and uneven. However, if the patient lets out a large exhale, you note that the height increase of one of the boxes then shows he was breathing shallow, then exhaled a high amount of carbon dioxide. If you see that.
Middle breathing?
Yep. So again, we got to get them to breathe and breathe normal. You got to kind of coach them. You'll be surprised at how much you can do with just putting in some supplemental oxygen on and coaching a patient to breathe better, especially if they're very anxious and they start hyperventilating. Hyperventilation, remember, also reduces that oxygen transport, therefore causes those carpal pedal spasms. It almost looks like they're having posturing at that point. Then they get really, really bad. All right. So what is occurring here when you see this? You're called to a nursing home. As you approach the patient, you note the patient is on O2 mask and lying semi-fowler. His chin is nearly touching his chest. You place him on capnography and you see this. Tell me what's going on based upon the waveform and observe this one carefully because something is just not right.
His chin is down, so he's cutting some of his airway. Should be sitting up higher, a little straight.
Okay. So you caught that part there, nearly touching his chest right here. What do you see wrong with this picture though?
That bottom line, it looks like it's going up, right? And it's kind of curved. Is that the curved one, the little shark?
No, down here you mean? This?
Yeah, yeah. It looks
Where
like
sh-
that third
Where
one
should
looks
that
like.
where should that be?
Should that be at the bottom at like at 0 or what?
Yeah, it should be
Like
down
it's
here.
equal?
Yeah.
Yeah.
Yeah, so this patient is doing what?
I'm
They're
not sure
rebreathing.
about that. I just know it doesn't look good.
That's fair. They're rebreathing. So the guy having his chin down to his chest, he's trapping carbon dioxide in that dead space where there shouldn't be any at all. So as they're taking a breath or as they're exhaling, rephrase it, as they're inhaling, there's still carbon dioxide sitting in that dead space, causing this to be up here around 5 because they're rebreathing everything. Right? So he's not clearing the dead space that would allow him to return to 0. Therefore, again, like Peter had mentioned, just picking his head back up again, that will change this and bring that back down to baseline. Right? So you start picking up in that rebreathing patient. All right. So this is a situation that many patients experience and we don't recognize this. Right? We don't want this to happen. So if you go to that nursing home call, you put them an end tile, and you start seeing this here, get their head back up. Lay them back a little bit.
Would you consider putting a collar on him?
You could, I guess, to hold it up. Just make sure when you walk through the ER doors, let them know this is not a trauma situation.
Yeah.
Why did you call in that trauma alert? Because it's not. But again, or just kind of lay them back a little bit. Not lay them flat, but just kind of, a little higher than semi-Fowler position. Enough to be able to sit and keep their head back. But if they're that tired, they can't keep their head up, then there's another problem at hand. Should they be getting a different type of airway? Right. So again, baseline never comes back to 0 because of the poor positioning. So this is what they call a rebreathing rhythm. All right, so diabetic ketoacidosis, DKA patients. So DKA is the issue where the insulin-dependent diabetic, or the IDDMs, and some non-insulin-dependent diabetic mellitus, the NIDDM patients, is that they do not have enough insulin available to break down glucose, aka sugar, for energy creation. So instead of the IDDM type 1 diabetics, and in some of the NIDDM type 2 patients, will sometimes have no choice but to utilize fat stores for energy production. Is what's it called? The term is gluconeogenesis. So fat for energy. So when fat stores are used for energy, acids called ketones begin to build up in the blood and urine. Ketones become toxic in high levels, and this is what we call the ketoacidosis. So in many cases, people find out that they have diabetes because they initially had a DKA experience, high blood sugars. DKA can start at as low as 250. Some patients can get it at 500. Again, it's all dependent on the patient, but they start getting that fruity smell, that ketone smell of the breath. You start seeing some changes with the respiratory drive, like that Kussmaul respiration and things like that, and start seeing elevated glucose readings. In many cases, they find this stuff out. These are all patients with very high blood sugar levels and whose breath smells sweet, or some smell like acetone. That's that ketone release. So buffering. Eventually, the body turns to a bicarbonate buffering system in order to balance the acid buildup. I am not going to go in detail on the buffering system with you guys on this lecture. That'll take another 4 hours. All right. So bicarbonate is a base that opposes acid, decreasing acid levels. The problem is that the system is quickly overwhelmed, and then the other mechanisms must work to compensate for the acidosis. So what does the body do? It triggers that hyperventilation to lower the blood CO2 levels. Hyperventilation being that Kussmaul respiration. So it's trying to hyperventilate to push out and lower that carbon dioxide level. So how do the DKA patients breathe? Remember that is what's occurring in these patients is ketones are building up, causing acidosis, right? So you have those high levels of end tidal. Because remember, anything high in this case here is acidotic for end tidal reading only, right? pH is different. Low pH is acid, high pH is alkalotic. But in the end tidal world, high numbers are acidotic, low numbers are alkalotic. This means that there is a high level of carbon dioxide in the blood. Therefore, what waveform will you see with this patient here? Elevated waveform. So here comes the interesting fact with this we were talking about before. We mentioned before that a patient that's hyperventilating will have low carbon dioxide. If they're in DKA, their body needs to attempt to correct acidosis, therefore is going to breathe faster. But because there's so much acid in the system, they're still going to have high readings, right? So this patient's probably going to be in a metabolic acidosis with respiratory compromise with this as well, right? So they're compensating respiratory, but they're in a metabolic acidosis of the compensation. So high levels of carbon dioxide in the body creates an acidotic environment. So if there's any paramedics in the room, you'll understand what I was just talking about with that compensation stuff. Where you're going to have that metabolic acidosis with respiratory acidosis as a we lost my train of thought for a minute. Compensating respiratory. All right. So we can fix this, but it's going to take some, but really what they need is insulin to bring those sugars down. But again, you can pick up this kind of stuff as part of your differential for this patient. Just like the case of the fast heart rate, a patient breathing this fast cannot keep up. So what occurs? The patient then begins a pattern of labored and deep breathing, Kussmaul respirations. Remember that in metabolic acidosis, in this case, DKA, breathing is first rapid and shallow, but as acidosis worsens, breathing becomes deep and labored, and then becomes gasping, which is that Kussmaul respiration starts kicking in. All right, and to finish up with shock, before that, any questions on diabetic ketoacidosis in the capnography sense? All right. Hearing nothing, we'll move forward. Nothing in the chat. All right. Perfusing warning. Capnography can provide an early warning sign of shock. A patient with a sudden drop in cardiac output will show a sudden or show a drop in cardiac output. It will show a sudden drop in end-tidal CO2 numbers that may be regardless of any change in breathing. This has an implication for trauma patients, cardiac patients, and any patient at risk for shock. So again, you're going to see that sudden drop in cardiac output will show a drop in end-tidal numbers that may be regardless of any change in breathing status. Right. So again, we got to kind of pay attention to that. Here's another pig study for you. 5 pigs had hemorrhagic shock induced by bleeding. 5 pigs had septic shock induced by infusion of E. coli, and 6 pigs had cardiogenic shock induced by repeated episodes of VFib. The pig's cardiac output was continuously measured as well as their PE TCO2. As a result, a patient with low cardiac output caused by cardiogenic or hypovolemia resulting from hemorrhage won't carry as much CO2 per minute back to the lungs to be exhaled. Therefore, this patient's end-tidal will be reduced. This doesn't necessarily mean the patient is hyperventilating or that their arterial CO2 level will be reduced. Reduction or reduced perfusion to the lungs alone causes this phenomenon. The patient's lung function may be perfectly normal. Right, so you're going to see that change. All right, this study was done in 2003. So when to use capnography, to kind of finish up here, capnography is not cheap, yet the benefits from the medic and the patients outweigh the cost. I say medic, EMTs, advanced EMTs, paramedics, if it's within your scope of practice, please use it. However, we still want to be selective when utilizing filter lines. They are expensive, but you need to make sure you're utilizing them for certain patients. These patients should be STEMIs, cardiac arrest, respiratory patients, patients on the sedation and analgesic medications, altered mental status, CNS infections, sepsis, drug E2H intoxication, hyperglycemic patients like DKA, right? Or patients with potential increased ICP issues. Remember that capnography is just another tool in your arsenal of equipment that can be utilized to further confirm your field diagnosis. Remember that your field diagnosis assists to lead you in your treatments. Also stated previously in placement of end-tidal filter lines are not intended for every patient. Instead, it should only be used for those patients who can benefit from its information. If utilized, please trend your findings after every treatment and document accordingly. Right? That is all I have for you. I'm going to stop the recording now, and then we can talk a little bit further.